well. So fantastic to have him as well. Dr. Lee Walker, ladies and gentlemen, I know you've heard him refer to his publications, more recent ones on blindness and the vascular occlusion. He's co-authored several chapters in medical aesthetic literature. Dr. Lee Walker has traveled and lectured in over 30 countries. Most recently, he kicked Australia off his bucket list. He spent about 16 days in Australia. I had the absolute pleasure to spend some great time with him as we traveled across the length and breadth of Australia, across storms, across sunny days that we saw in Adelaide. So let's see if we can squeeze in a couple of anecdotes of his Australian trip into his presentation. Ladies and gentlemen, Dr. Lee Walker is a global key opinion leader for Teoxan. He's also the global faculty co-lead for Teoxan. So he does fantastic work in developing several up-and-coming key opinion leaders. It's a pleasure to have you, Lee, with us today.
Thank you.
Okay, brilliant. The introductions are done now. Ladies and gentlemen, the setup is going to be Dr. Wilson Ho. Wilson, if you can get your presentation up and running while I talk through. Dr. Wilson Ho is going to give us a talk on general complications. He's going to cover ocular and vascular occlusions. After his talk right away, we'll get Dr. Lee Walker up to talk about the anatomy of the lower face and the complications that can occur. More importantly, what you should recognize, avoid, and manage if you do come across some brilliant talks. After the end of Dr. Lee Walker's talk, Dr. Wilson Ho and Dr. Lee Walker would moderate. So please type in your questions in the Q&A box or in the chat box. They're going to spend a good 20 minutes talking through each other's presentations and discussing, as I said, recognizing, avoiding, and managing complications. So you're going to get a lot out of this to enrich your practice, and more importantly, so that you can go to bed as you practice the Teoxan approach of ATP. The best question to get a book authored by Dr. Lee Walker, Facial Aging Anatomy, or Injection Anatomy Considerations. So please type in your questions. As the both speakers decide the best question is, they're going to call it out, and we'll make arrangements for the book to be sent across to you with your email. So please stay tuned, stay till the end, put in your questions. Without any further ado, Wilson, if I could get you to take over the floor and give us your presentation, please. Thank you.
Thank you very much, Chris, for your kind introduction. Melanie, can you see my slides?
Yes, we can. All good. Go for it.
All right. Thank you once again for Teoxan for having me for these important topics where I think most of the pharmaceutical company they try to avoid. And I think this is very important topics we need to face and as a clinician day in and day out. Now, while we love to show our patients the great result we have, there are dark sides from injectables. Whether it's a result of your poor technique or the wrong selection of product or misunderstanding of the aesthetic ideal, or you are missing the ideal and aesthetic endpoints. Now, while most of the complications of atrial fillers, they are mild and transient, there is a very, very remote chance that you will have end up with serious complications with permanent consequence, including skin necrosis, blindness, or stroke. Now, if you look at the standard textbook, the complications for forever fillers, they can be classified into the early onset and the delayed onset. Now, most of the complications that belong to the early onset group. As we know, injection site reaction will be the most common mild complications. And then I think nowadays the overfilling, or what we call the overfill facial syndromes, are very important because we are too eager to treat. And many a time our concept is based on volume-based injections. I'll focus on that later. And then immediate and delay hypersensitivity reaction infections. I would focus more on later on the ocular complications, and also in particular vascular complications. Of course, you will have some foreign body granulomas as a delay onset adverse effect or delay hypersensitivity reactions. Okay, I'll go through that very quickly. So as I mentioned, most of the injection site adverse effects, they are transient and mild, including swelling, all kind of atrial filler, they will cause some kind of swelling, but most of the time they are negligible and transient. I'm talking about within a couple of hours or within one day, the swelling will settle down. And the pain pretty much related to your technique. There are many ways to ease the pain, including topical acidic creams, ice pad, or nerve block, which is very easy to manage. Most of the prolonged pain perhaps related to overfilling or bleeding inside the injected area. Erythema is very, very common, but very, very transient as well. Ecchymosis, it can be prolonged. It's one of the most common complications from your needles or cannula. And some of the ecchymosis can be very can last for weeks, while most of the bruising, they will subside within 5 to 7 days. This is a patient of mine who suffer from prolonged ecchymosis, which lasts up to 5 weeks before it subsides after filling up the nasolabial fold. And sometimes it's quite difficult to differentiate a ecchymosis or bruising from intravascular event. Okay, and this is challenging. We can't tell for sure, no matter what all the clinical examination you try to do, and sometimes you can't tell for sure. But in case of any doubt, we're going to inject hyaluronidase. Just assume, if you can't be sure, just assume it's an intravascular event. Surface irregularity and nodules. I think nowadays with atrial fillers, mostly related to overfilling. And of course, if you inject the atrial fillers into the wrong layers or choosing a wrong product, for instance, a very hard gel, you inject into the superficial, the fat layers, then you end up with nodules and irregularity and high bolus injections as well. Now, this is a typical example of a high bolus injection into the upper lip tubercles, which lasts for up to 6 months and still a nodules there. And despite the repeated injection of hyaluronidase, what happened, I think, is there's a capsular formations. And the patient just, after maybe up to 12 to 14 times of hyaluronidase, should just take what it is without considering maybe a surgical removal. This is a patient of mine referred from another aesthetic physicians where she complains of visible and palpable nodules over the nasal bridge after a atrial fillers injections. And once again, despite repeated hyaluronidase injection, the nodule is still there. So, and we end up in surgical excision. What happened here is a capsular formation around the atrial fillers. You can see the capsule, which is here. This is the capsule. So immediate hypersensitivity reactions or the delayed hypersensitivity reactions, I would say, is relatively uncommon, especially among Asians. I think it is more common among the Caucasians. Sometimes you can encounter a situation like this. This is kind of severe erythema immediately after the injection into the left temporal area. The patient complained enormous discomfort and itchiness over the periorbital and the temporal area. So you need to stop this injection immediately and consider those and anti-hypersensitivity treatments. Now, this is a tricky case. The patient came back 2 days later after atrial injection filling into the lips. So why is it tricky? It can be an intravascular event, or it can be a hypersensitivity reactions. It's quite difficult to tell at this moment. Once again, if you're in doubt, then you treat it as an intravascular event. So delayed hypersensitivity reactions, as I mentioned, is uncommon in Asians. However, it's still there. It's there, especially related to some kind of product. This is my patients. I inject the atrial filler into the medial cheek, the tear drops. So this is what she looks like immediately after the injection and then 1 month post injections. So this is the quarter wheel. And then she came back around 7 weeks later with a sudden onset of painless swelling over the face. So this is, to me, this is a delayed hypersensitivity reaction to certain product, which has been published in the literatures, which is highly related to a cross-link technique with low molecular weight molecules. So I'm not going to mention the product. So this is one of my patients, and she settled down with broad spectrum antibiotics. Another patient of mine using the same product injected into the preoperative area, including the upper eyelid, hollow, and also the teardrops. This is what she looks like immediately after the injection. And then she came back a couple of weeks later, once again, with painless swelling around the eyes with mild degree of erythema. So I treat her once again with a full course of broad spectrum antibiotics, and she settled down with that. Okay. And then infections. I would say infections is rather uncommon with proper antiseptic techniques, but there are reports of herpes simplex virus infection, which I have never encountered before, or abscess cellulitis. Yes, maybe a handful of cellulitis cases in my past 19 years of doing X-ray injections. A mild TB infection, mild bacterial infection, I've never encountered that. And most of the time is, I would say, is the bacterial infections. A patient like this came back a few days later after atrial fillers injection into the nose. You can see there's a slight erythema with pimple-like posture there. And she settled down with antibiotics without any explorations. This is from the classic textbooks, a herpes formation after atrial fillers injections, which I have never encountered before. A patient picture sent to me by my colleagues from mainland China, and she had an injection of atrial fillers into the mid-face, temporal area, and also the mandibular angle. And this is what she looks like a couple of days down the road. And I think that is the abscess formation, and eventually she needed a surgical exploration. And another case, she went to a beauty partner with unknown fillers injected into the nose, nasal area, and also the tear drops, and then to end up with gross swelling like this, and she needs IND later on. Now, nowadays, I think one of the most common and alarming complication of atrial filler is overfilling, because a lot of the pharmaceutical company, they push forward for volumes, for syringes, ask you and teach you how to do the big bolus injections here and there. You end up with something like this, because the whole concept, what I call the volume-based injection concept, is that you try to correct all the issues, either from structural issues or from aging process, from injectable alone, i.e. volume loss, i.e. tissue migration, sagging, and also the skin changes and so on. With injectable alone, with fillers alone, you end up something like this. For mild degree to very severe one. In severe one, it will cause irreversible anatomical damage that cannot be treated by any means, including surgical means. So this is something that gives bad names to atrial fillers or any kinds of fillers. A patient, young patients, he went to Korea and have a double eyelid surgery, medial epicanthaloplasty and injectables virtually all over the face. And he ended up like very, very strange looking, a over balloon, overfilled face, very unnatural and appearing. This is a disaster to me. So my good friends, Lim Kim Song from Malaysia, and he mentioned about this facial overfilled syndrome. It's a typical, you can see, I would say, it's all around us, including celebrity. And trust me, if you go to Australia, you will see more of that. And if you go to Hollywood, you will see a lot. So this is one of the actor from Hong Kong. He's very famous. And so this, unfortunately, he ended up something like that. You can see there's a narrowed down of the optical apertures. There was an overfilled midchie, and he can't even smile properly. And the whole face is distorted, including distorted proportions and so on. So it's not just about the aesthetic appearance, but also the change of the whole appearance, including his facial expression. And imagine he's an actor, so that would be a disaster. Now, this is a case not because of the, not much related to the overfilling, but a wrong choice of product. Think about it, the lip is a very soft tissue. If you ingest something behave more like a bone, you will end up something like that, despite you control the volume. So nowadays, I think we need to think beyond volumizations. We need to take care of the underlying changes or underlying pathophysiology accordingly, using different or combined treatment modalities, such that to give you the best and safe and natural result. So as a plastic surgeon, we always deal with volume loss, tissue migrations. Okay, so what we want to do is to fill up the, replace the lost tissue and also tissue repositioning, either by surgery, by frets, by high energy-based devices or neuromodulators or combination of treatments. So this is a very young patient. She doesn't need any volume at all. This is what she looks like. Look at her right face after radio frequency treatment over the right face. And you can see there's obvious tightening of the skin with a mild degree of lifting. Another example, without any filling, a patient of mine who had a flat lips to the medial mid-cheek only, to the mid-face only. All right, you can see the change, the improvement in the tear troughs, in the nasolabial fold, as well as the Marriott line. And one more thing is that you can see the elevation of the eyebrows and the appearance of the double fold, despite the fact that there's nothing being done over the upper face. So what's going on is what I call the rebalance of the muscle behavior because of the tissue repositioning. Why I'm saying that, what I'm trying to say is when you lift up the mid-cheek, you're going to give the support to orbicularis oculi muscle, and such that you relax the muscle. And that's why there's a brow elevation with more obvious double fold. Another, once again, she doesn't need any volume at all. What she needs just some tissue repositioning, once again, with frets over the mid-face only. Okay, a very natural result, improvement in the fold, in the nasolabial fold, the Marriott line, as well as the brightening up of the eyes and the brow elevations, and better definition of the jawline as well. So many times, the treatment is a combination TRRT, the tissue repositioning and replacement therapy, is about a combinations of therapies. What she received would be neuromodulators, atrial fillers, plus high energy based devices. So with minimum downtime, if not no downtime at all, we managed to rejuvenate her in a very natural and safe way. So beautification strategy is all about respect the tissue pathophysiological changes, respect patient's unique aesthetic beauty as well as ethnic background. So this is what she looks like, a very subtle change. People will notice there's a change in terms of you look brighter, younger, and more attractive, yet nobody knows what have done on your face. So that's not just applied to Asians or Caucasians, but also Eurasians. Very subtle change, less is more. This is what we need to achieve for our patients, beautification in a natural way. So I'm going to spend a little bit more time on the ocular complications, because this is the area which is the most challenging area to get a good result and the most unforgiving area, the area that easily end up in complications and patients' dissatisfaction. So I think in the good old days, Tyndall effect is one of the most common complications because of the product we use. I would say if you use the monophysic, the particulate and X-ray product, you will have much higher chance of Tyndall effect because of the light refraction properties. And of course, if you have creepy and thin skin, you can have a Tyndall effect much easier. And that's the reason why if you fill up the teardrops for the Caucasians, superficially, you probably will end up with more Tyndall effects. Now, Tyndall effect can appear everywhere, and teardrop is the most common area, and perhaps the next one would be the nasal dorsum. Okay, especially when light is shining over the patient's overhead, over the patient's face. So you can see both Caucasian, you can see the bluish discoloration. This is called a Tyndall. This is Tyndall. Underneath the sunlight, it appears more obviously. So this is product related, and also patient selection and the placement of product into the superficial area. What the other very common, and I would say, issues about filling the teardrops area is these worms. Okay, can you see these worms over the teardrop area? And this worm appears only when patients have animations. Okay, it won't appear when patient has no facial elevations. So this is something related to the hyperactive medial lower aspect of the orbicularis oculi muscle, plus a bit overfillings. So my advice nowadays, and which I will always do whenever I do my fillers, I would not just check my patients in static situation, but also will do the assessment in patients with facial animations. So if sometimes you can see these worms appear without any fillers before, then don't fill up this patient until you relax the medial lower aspect of the orbicularis oculi muscle with your neuromodulators. And then after that, maybe 1 week down the road, and you decide how much product you're going to raise to fill. And I think periorbital area is one of the most common area where you have blues, especially prolonged ecchymosis. This is a patient, you can see the ecchymosis, especially over the left side of her periorbital area. And this is a picture taken more than 6 months ago. You might wonder why the ecchymosis can last for so long. And that also bothered me for a long while until one day I figured it out. I think what's going on is the blood being trapped between the product. So, and that's the reason the blood clot or the blood could not be removed by the circulatory system. Okay, so what can you do about it? And I think we can do nowadays is quite easy. We can use pulsed laser, just treat it as a hemangioma or blood vessel neoplasm with your PDL pulse laser, which responds very well. And then nodularities, easy to form those nodules. If you inject a big bolus, if you inject superficially with a large volume than needed, when you choose the wrong product, that means a very hard and sticky gel into the superficial layer, you end up something like this. This patient referred to me. You can see this nodularity, especially over the left side, right side of the lower eyelid. And once again, and this is after several times of hyaluronidase attempt to dissolve the product. And what happened is just same as the cases that I present previously, is a combination of nodule with capsular formations. So without any surgical means, I treat her with repeated injections of hyaluronidase and steroid. Now, for the upper eyelid hollow, it's very, very challenging because this is a highly mobile area. You're not just taking care of the hollow while the patient with the eyes open. You also need to take care of it while the patient close their eyes. You try to underfill this area because many times when they will look good, when they open up their eyes, when they close their eyes, you will see a bulge. So this is a case where you inject too much into the superficial layers. And sometimes this swelling only occur 24 hours or more after the injection because of the swelling or the hydrophilic properties of the product you can choose. So always inject conservatively. When I inject into the upper eyelid hollow, I always inject underneath the occipularis oculi muscle and do it with very, very conservatively. And then in other patients that try to fill up the upper eyelid hollow by physicians, and he inject too aggressively and too deep, and end up in the ptosis on the left side. So that only resolved after repeated attempt of injection of hyaluronidase, which gave the mechanical block. That's why the ptosis. And other patients try to refer to me, trying to fill up the upper eyelid hollow with X-ray, and then end up with something like that. And the patient, and the physician who injected her was scared to death. So she was referred to me immediately, and I invited an ophthalmologist to join me. What happens is the filler being injected just subconjunctivally with blood bleeding inside. So what we have done, we just inject a little bit of hyaluronidase into this lump. This is what she looks like a week after that, with still some ecchymosis there, which took more than 3 weeks before subsides completely. And luckily, there was no visual impairments or any long-term issues. So I'm going to move to another very serious event, which we need to aware, and we need to pick up as early and treat as early as possible, because many times we can reverse the process or control the damage by early recognition and treatments. And I think the vascular occlusion occur most commonly over the central face, because this is the most vascular area. And the number one would be the nose, followed by nasolabial fold, and then the glabella. The blindness was most often associated with the glabella. 50% of the blindness associated with glabella. There are reports of stroke after injection into this area as well. Although the incidence is extremely low, the consequence is really, really severe. That's the reason why we need to recognize that. I have several cases of intravascular event, and luckily all of them were mild. And in my 19 years of injectables, you may question why in Asia we have more intravascular events than the Western world, I would say. I think mainly because most of Asian they need injectables for fearless injection into the central face, where the Caucasian is more often on the posterior face instead of the anterior central face. So intravascular events can cause local tissue necrosis. Most commonly, as we mentioned, 1/3 occur in the nose because this is a very vascular area, and you can easily get into trouble injecting intravascularly. This is a patient of mine long time ago, maybe 15 years ago. I thought, oh gosh, this is the first herpes simplex I ever met. And I treat her as herpes simplex. And in which respect, this is a picture. She came back 5 days later. She complains of a little bit blister over here, a little bit bruise. But if you examine her closely, and this is a very minor case of intravascular event with cold abscess, what I call cold abscess over that area. And luckily, no matter what we do, even without treatment, she'll get rid of that. So that's number one lucky case. But sometimes you can have severe one. And luckily, these cases will not belong to me. And more severe one and end up in tissue necrosis. Okay, and there are a lot of a protocol of how to treat intravascular events. You can easily find it in the internet. So, but I as a clinician, I think the most useful thing is repeated injection of hyaluronidase. If you inject HA very frequently, you must have at least 5 to 6 vials of hyaluronidase available in your clinic. If you don't have one or don't have enough one, make sure your colleagues nearby, they have some. You can borrow from them very quickly. So intravascular event, treat them with repeated injection every 1 hour until you can see the improvement with hyaluronidase. Okay, hyaluronidase is the most important thing. Don't waste your time trying to coordinate the hyperbaric oxygen treatment and otherwise. You will waste your time. These are kind of treatment for secondary healing intentions, not for the primary one. A young man after the nasal injection of HA products, you can see this is what he looks like. There's a blinging with surrounding erythema, and this is what he looks like maybe 8 days down the road. And you will see there will end up with permanent scarring. Okay, unfortunately, no matter what you do. And then local tissue necrosis, the second common place would be the nasolabial fold. Why? Because you can see when you inject the nasolabial fold into this buttress triangular area from facial nerve, is quite superficial. It's just in the superficial fat layer. It is quite big. Okay, so it is very easy to hit into the vessel and give you intravascular events. So this is a kind of typical presentations. Not immediately, maybe 2 to 3 days. Now, I can tell you most of the time, the patient will experience mild to moderate pains. Apart from that, they have no symptoms at all. And then they came back to you a couple of days later. They will find out, oh, why I have prolonged bruising. And then you will say, oh, gosh, this is an intravascular event. All right. I have 2 intravascular events after injection into the nasolabial fold. And this is another pictures where you can see these cold abscess, these ecchymosis. All right, more severe one. These are typical. This is a patient of mine. He came back 5 days later. This is a picture. 5 days I inject into his nasolabial fold. He experienced moderate pain over the injected area. Okay, and then he thought this is a blues. It's a severe blues. But out of unknown reason, he decided to come back. Okay, so and luckily it's not severe, and we managed to tie off without any permanent damage. Okay, one particular thing happened in 2 of my patients with intravascular event over this area is that they will have some kind of nasal discharge within 24 hours, and that can last up to 2 to 3 days. Okay, I think because of the irritations or the ischemia causing reactively mucosal secretions. And once again, local tissue necrosis of the central face, glabella, and the forehead. Okay, that can happen because, as I mentioned, this is a very vascular area. Now, intravascular event can occur anywhere over the face. I will leave the lower face to Lee because he's going to concentrate on the lower face. I'm going to talk about in general. Now, you can see in this patient, you can see this discoloration over here, over her left face. The injector performed a on stage using a cannula, try to use this fanning technique to demonstrate how he did a hydro lifting with HA. So in the middle of his demonstration, the patient experienced severe pain and something like that. So I think what happened is he inject some of the product into the superficial temporal artery. And this is another case after HA injection into this temporal area, into the superficial temporal fascia, end up in local tissue necrosis. This is into the upper lip, intravascular event. This is what she looks like around 5 days down the road. I will leave it to for Lee to talk about. Now, blindness is most striking and frightening event. As I mentioned before, 50% of blindness was associated with injection into the glabella. Why? Because the supratracheal artery is so close to your injected area and so close to the ophthalmic artery, and that's the reason why. There are other areas, including nose, nasolabial fold, and temporal. These are the common areas. You can end up in blindness, even you inject into the lower face, although I never encountered any of these cases before. And you can see if you inject into this area, the supratracheal artery is waiting for you. When you inject into the nose, you have the dorsal nasal artery, you have the angular artery waiting for you. When you inject into the temple, you have the superficial temporal fascia to superficial temporal artery waiting for you. And this is kind of the presentation. These patients end up with visual impairment after injection into the nasolabial fold. Okay, this is the patient. And this is the patient with complete blindness after injection into the glabella. Okay. All right. And Jane Carruthers together joined with Steve Fagan. They published a paper in Derm 8 years ago talking about how to treat intravascular event involving the eyeballs. So first of all, when patient experience ocular pain or visual impairment or visual loss, you need to stop the injection right away and try to invite an ophthalmologist in to help you to do the retrobulbar injection of hyaluronidase. And there are some courses, even nowadays, cadaver courses teach you how to do the retrobulbar injection and try to save the visual, the visions. But I try to do my due diligence search all across the website. I've never seen one paper being published that you can save the vision by doing so. Okay, they perform this kind of study on the animal model, on the rabbit, but the human eyeball is different. So up to this moment, I don't think this is this is verified by our clinical experience. Now the question boils down: how can we prevent vascular complications? I will tell you, can never prevent. that will happen to you. That will happen to you if you inject more. The more you inject, the higher the chance. But there are some techniques that Wolf mentioned. We can reduce the frequency or the chance of intravascular events. But nowadays, with a lot of people, they are not filler naive. So with fillers injection into the face, they have distorted anatomy, or they have distorted anatomy because of period trauma, including surgery and whatnot, or they have just some anomaly of the vaso anatomical structures. Then you end up something intravascular events. So I always preach for small bolus injections and inject slowly and no pressure. Okay, when you inject, you just move your needle a little bit around. So even you inject a small amount into the intravascularly, you won't have clinical implications. So aspiration, we've been debated about aspiration, whether Wolf aspiration or not, for the past 10 years. First of all, I think if you believe in aspiration, you better do it properly. First of all, aspiration, you can do aspiration only with your needle, not your cannula. You will look very silly with your cannula trying to aspirate, because this is a kind of maneuver which works only with needle, with proper technique. You make sure you aspirate enough time, because 2/3 of the possible aspiration occur only after 1 second. You don't try to do it as a virtual, okay? And it's product related in the sense that you need to use the proper needle size. If the product is highly cohesive, then you probably need a bigger needle size before it can give you a prostate aspiration. And also, this is only feasible in your clinical practice if you practice those point injections. Okay, many times it's not feasible at all, because whenever you inject, you need to aspirate. Whenever you inject, you need to aspirate. And bear in mind that negative aspiration does not mean you are not inside the vessel. You still need to observe any severe pain, any plunging, pain, especially outside the injected area. Then you need to stop the injection right away, and then check the circulation around the injected area and the surrounding area. Ask the patient to stay in your clinic up to 30 minutes. In doubt, you inject hyaluronidase. You only let your patient go after 30 minutes if you're comfortable with the circulations. Now, another area that we'll debate would be the needle versus cannula. Whether needle is safer than cannula is debatable. And there are more and more clinical cases that happens of clinical cases of intravascular event that's after the use of cannula. And this is a positive aspiration result that happens in one of the training sections. I think it is very important. Go back to your anatomical study in the cadaver dissections. Nevertheless, we are treating human being. I think the surface anatomy is the utmost important things. Bear this in mind with proper training. Once again, be mindful of intravascular event and don't be scared. I'm not trying to scare you off. Enjoy your injections. After all, most of our patients, they enjoy the good results. Thank you.
Apologies. Thank you, Wilson. A concise and very interesting lecture. I'll share my screen and we will sort of link the two areas together. What we're going to look at in particular here is the anatomical dangers in the lower face. And I can see that we've got a few questions already in the Q&A box. Remember, with education, education starts and continues with questions. So please keep placing your questions into the chat box, and myself and Wilson will endeavor to answer all of those as we go through. An introduction to my part of this very interesting expert webinar is a case presentation. I think it's incredibly important that we look forensically of and retrospectively of how things have happened and how we can avoid in the future. Also going to look at the pathophysiology of vascular compromise. Wilson has beautifully sort of illustrated this in a series of cases which are incredibly important for you and your development. Then going to explore some of the vascular anatomy of the lower face. We'll focus on some of the danger zones. And then what's very important for us as injectors and anatomists is suggesting which planes, facial planes are lower risk for your injections. You may notice that I've not put the word safe in. I think we need to remove the word safe from injection anatomy because there are no safe areas of the face. We just have areas of risk. Like I said, I often see other speakers or trainers talking about vascularity and how it's safe to inject into these zones. So for the sake of clarity here, is this area safe? Is this safer? Or is this the safest? Well, you're going to have to think about where the tip of your needle is relative to the tissue planes. I think that is one of the more important aspects of this talk today. It's not distribution. Distribution is incredibly variable and depth is the more constant that we have. It's not perfect, but it's certainly more of an idea of how to inject. Wilson had discussed a needle and cannula, and what we've got to look at is the evidence base behind these instruments. If you look at this large study, this is the largest study which is conducted on needle and cannula. And what we can see here is that 370 dermatologists reporting 1.7 million syringes, so huge numbers here, observed 1 in 6,410 occlusions with a needle and 1 in 40,000 with a cannula. So looking at the statistics here, with a cannula, you have a 77% lower chance of an occlusion than a needle. Again, it's not saying it's safe. It's just saying it's lower risk. And again, that's what we're going to have to think about as we move through this session. Nasolabial fold and lips were the most likely to be occluded, and the highest levels of occlusion were at the glabella. So they were the most severe. So my key today is really getting you to focus on three-dimensional anatomy, which is both the depth and the distribution of these vessels in the lower face. And I'm going to try and make it as simple as possible because simplification really here is the key. So this is the case study that I'm going to present, which is a relatively recent one, which I helped to navigate through with the practitioner. So here, again, quite an unassuming picture of a chin augmentation. 0.4 ml was used in total, so quite a small amount. Around about 0.2 was injected with a needle into the pre-jowl area. And as Wilson has said, that aspiration can help and can hinder you in some aspects. So this case was a negative aspiration. The injection was painful. It was above and beyond what the patient was experiencing, and the pain radiated to the floor of the mouth and to the neck. And this picture here is 20 minutes post-injection. So when you look at it, you're probably thinking a little bit of erythema, mild hematoma, nothing really to see here. Again, the practitioner in this case was a little bit worried about the color of the skin, kept the patient behind for a little bit, and was wondering whether or not this was a hematoma or a vascular compromise. And that is normally what most practitioners think. they think it's just a hematoma, and they don't show that due diligence, and they will discharge the patient. And again, a lot of these things that we look at forensically, your patients, your practitioners tend to have a little bit of professional denial because they don't want this thing to happen to them, and rightly so. So one of the things you have to do is, if you're concerned with the skin color, then capillary refill time is one. But again, just keep your patient behind so you can monitor their skin for the next 30 minutes. So the practitioner sent the patient away, and 3 hours later, there was increasing pain in the chin and neck area, and also the floor of the mouth. And what you can see here is a series of different sorts of textures and colors within the neck and chin area. You can see the dark blue discoloration, you can see a pink and red, and also you can see a white or blanched area here. So at this time, the practitioner was pretty upset. The patient was in pain, and it was advised to the practitioner that the patient had a vascular occlusion after the chin injection, which was in fact affecting both the neck and the floor of the mouth. So we'll look at this video, and again, this is around about an hour later. And what we're going to look at here is a capillary refill time should be 1 to 2 seconds. And what you can see here in the neck here is that classic delay. And this will tell you this is a symptom of a vascular compromise. There is no blood flow back into the area, and it's arterial insufficiency. So the practitioner decided to place 500 units of hyaluronidase in a 2 ml solution with saline, and following the injections, we can see here that really nothing too much has happened in terms of capillary refill time. So there is still an obvious blockage here with this patient and with the perfusion to the chin. So what we decided to do was to have a chat with the practitioner and tell her to increase the amount of hyaluronidase to 1,500 units in 1 ml of 1% lidocaine without adrenaline. And we'll discuss the reasons or the rationale behind this as we move through. So they repeated the protocol. This was, they still used 500 ml here, but again, this was 1 hour later after the first bout of hyaluronidase. You can still see there is a significant capillary refill time here, so that the occlusion still hasn't cleared. And this is one of the frustrating things that we see as practitioners, is that you don't put enough hyaluronidase into these areas. You've got a high HA concentration, you've got high cross-linking, normally high volumes here. And we need to understand the drug itself. Hyaluronidase is a dispersal drug, so it will move away from the site. It will increase tissue permeability. So the more hyaluronidase you put in, the more it will disperse away from the site. So again, we suggested to the practitioner to run with the protocol of 1,500 units in 1 ml of lidocaine, 1% adrenaline-free, and repeat every 15 minutes. They did this, and the patient felt instant relief in the neck, the chin, and the floor of the mouth area. And they continued that for a couple of hours. And this is the occlusion 10 days post. And you can see that the area is completely clear now. There is no skin breakdown. There is no scarring with this. The images that we had were at the beginning. The practitioner decided to just run with the protocol and discharge the patient after capillary refill time was back to normal. And this is the last image that we received. So with that high dose pulsed hyaluronidase with very concentrated hyaluronidase, every 15 minutes, the occlusion cleared. And again, this is not an uncommon area. This is another one that we have to tackle earlier on in the year. But again, this is compounded by an area on the chin which looks like necrotic tissue. That wasn't actually necrotic tissue. That was the fact that the practitioner had placed a hot towel onto the patient's chin and caused a burn. So you can see that there is a mixed picture here, mixed sort of session. And what we can think about here is capillary refill time is incredibly important. It will really distinguish between a hematoma, the clouded picture of repeated injections, and also vascular perfusion. So this area in the chin is very common. So what is a vascular occlusion, and what is the pathophysiology behind this? So why did this case happen? Why did it look like it did? Why was the capillary refill time? Why was it blanched? Well, we're going to go through it. So regardless of skin tone or color, you will always see a reticulation onto the skin. And this is an important diagnostic sign. It's incredibly important that we look at these signs and we don't ignore them. So again, videos are very good if your patient's far away, or standardized imaging with good lighting. Again, videos of capillary refill time are very important. Is it compression or is it intravascular? Again, we often hear people talking about compression. Actually, all of the literature available to us suggests that the mechanism behind these vascular occlusions are all intravascular. So compression, in my humble opinion, and again, studies with animals, they did a mouse's ear and they ligated the vessels off and tried to compress it, and they still couldn't compress a tiny mouse's ear with a significant amount of HA filler. So again, we're going to have to think about what the phenomenon is. So I'm just going to take you back to a medical school a little bit, because this is really fundamental in understanding vascular occlusion. So healthy pink skin is a harmony between arterial and venous blood supply. And on the skin here, we can see that the skin is perfused by arterial cones and by venous cones. And basically what you have is an equal playing field between venous and arterial dominance. So this is that wonderful pink appearance we have to the skin. What happens if we compromise that delicate balance between arterial and venous? Well, we get reduced blood flow to the area. We get a dilation of the venules. Significant bleeding is not always present here. So again, you'll have this arterial insufficiency. And this was in the case study. So again, taking images from different angles here, you can see that there is a blanching of the tissue in the neck where you started to see that very obvious reticulation as you move through. And this is why it's very important to get good lighting, good clinical photography, and also using capillary refill time. This is what happens. So this is an angiosome, or an area of skin which is perfused by a vessel. And if you block the vessel, or the vessel goes into spasm, what you will have is the whole area of the angiosome affected. So this is where you're going to see that sort of white appearance here. And this is very unique in its physiology. So the anatomical basis of this blanching is here. You can start to see that when you block the arteries supplying the skin, then there is no blood supply to those zones of arterial dominance. So what you have then is an area which is devoid of blood, and this is how it manifests itself onto the skin as this area of blanching. Now, blanching is not always obvious, as we've seen with the case study, and sometimes it's often fleeting, so it will appear and disappear due to collaterals. Also, you may miss it if the patient is wearing lots of makeup, or if you've got a big bright light over your patient, or you're not using skin vigilance, so you're not watching the skin as you inject. Your second stage is livedo. So this livedo reticularis means blue, or blue web. And you can see here on this image of my dear friend, Dr. Tony Burke, you can see that there is a strange pattern appearing. So again, our understanding here is that this can be painful, this mottled skin. And what you have here is venous congestion. So now you have blocked arterial cones, and now you have a dominance of deoxygenated blood within the skin, within these little arterial, between these little arterial cones. You'll start to see reticulation. And this is what it is. So we start to see these blocked arterial cones being encircled or encapsulated by deoxygenated blood. Our third stage is normally around about 2 to 3 days post-treatment, and we get a disruption to the skin barrier because we have no oxygen to the skin. So we start to see a commensal overgrowth, we start to see sterile inflammation, pustules appear, reduction in pH, sebum onto the skin. The ischemia can or cannot still be present depending on capillary refill time here. And what you can see here is a classic stage 2 and stage 3 overlap. So you can still see reticulation of the skin. But this time, the overlying area of occlusion is punctuated by little pustules of sterile inflammation. So again, you can have a mixed picture here of this, and it's incredibly important that you can to understand that you can still use hyaluronidase at this stage. Your stage 4 is you're really getting to sort of some deep water here, and if you all get into the coagulative stage of a vascular occlusion, then you're going to have to think, have I used enough hyaluronidase? Should I have referred this? Am I managing this patient well? We've now started to get erythrocyte congestion and coagulation, a breakdown into the tissue. The architecture of the skin is becoming very, very firm here. And your stage 4 will lead to stage 5. And Wilson showed you this on the nose. This is eschar formation, cell death and rupture of the contents. The skin is now breaking down, lots of denatured protein. And this is now a wound management issue. So again, you can forget your hyaluronidase. At this point, you're on pretty deep water, which will need some advanced wound care. If it gets this far, again, you're going to have to question, could I have done something different in the beginning? Maybe identified it quicker, maybe use some hyaluronidase, maybe use lots of hyaluronidase in shorter time periods, maybe using lidocaine instead of saline without adrenaline. Again, these are all the key questions that you need to ask yourself if you get to this part. So how do we avoid? Understanding and respecting anatomy is incredibly important, and it gives you an opportunity to mitigate your risk. It's not perfect because everybody's anatomy is different and there is ethnic variability here, but you're going to give yourself a chance if you know the anatomy. So this is some of the vasculature and its relationship with the muscles in the lower face. Again, this is our target we're looking at today. So the facial artery will give off a submental branch. And again, from this submental branch, you can see that there is quite a complex network of vascularity. Also, the mental artery is a branch of the maxillary artery, comes from the inferior alveolar, high up into the infratemporal fossa to perfuse the chin and the gingivae and the lower teeth as well. So this is important that the blood supply to the lower face is coming from multiple sources. Again, if you look at your distribution here, you can start to work out how to avoid some of these important vessels. Your mental artery here just lateral to the middle, and also you have mental artery in line with the first or second premolar, which is below your DAO. So if you can find your DAO, you can find your mental artery, and again, you're going to avoid a deep injection into those positions. This is from a lateral view, and what you can see is those multiple sources of how the door is perfused. And again, you'll have vessels going to dip of the chin, and also top floor of the mouth, and to the cold surface oral also. This gives you a beautiful dissection of the vessel, and you can see the facial vein, the inferior line from the core. What we say generally is that vasculature here is deep. Is above the commissure. It changes its name to the angular artery. Is the vessel starts to become superficial. So we're starting to understand it here. We're starting to understand the depth. And this was quite a nice publication, again, by a Thai, very popular with the interest in anatomy and injection. And what they're using now is ultra to look at the vessels that was really that reported was this, the mental artery. Where does this come from and what's so important? Well, the submental artery is the largest branch of the facial artery in the neck, and it will along the border of your mouth, feel the mandibular gland. And here you can see the submental artery is entering the channel to mine, almost in the radial area, in a superficial plane. So again, that gives you an opportunity to understand the position and the depth of this vessel here. So perfused, and the neck, which is incredible, because what we always have to remember is that there is a process between some of the vessels, which are super vessels. We know both the facial artery and artery are significant branches of the external carotid artery. Both of those come off into the neck and enter the face and floor of the mouth. And this is part of the deal here. If your patient has a floor of mouth involvement, a neck involvement, you know sublingual and submental have been affected, so you direct your hyaluronidase treatment into those areas. So how do you look at these lower risks? Well, again, you delve back into and the literature, and you can
Recording in progress.
instruments of choice here will reduce and further mitigate your risk further down. What we always have to think about here is deep versus superficial, and you can see a large mental foramen here with the mental artery and nerve coming out of this, quite a significant vessel. So we have a multi-plane vascularity within the chin, and this is one of the reasons why it's often a common area for vascular compromise. So how do you avoid this? Well, your ascending mental artery is 6 millimeters lateral to the midline. Depending on your BMI, then the depth from the skin is 4 millimeters. And we've seen on the images previous that subcutaneous position is around about 30% and intramuscular 70%. So that leads you to understanding that maybe a lower risk plane of injection would be just midline into the chin with a volumizing filler like Ultra Deep we're using here. And then if you are going to go superficial, then this is my recommendation is to give small linear threads with a cannula. And again, this is going to mitigate your risk. It's not perfect. Okay, nothing's perfect when we breach the skin envelope, but we can start to understand our injection strategy and our product choice and our technique. And that really is the basis of what Teoxane stands on, which is ATP. So anatomy, aging, assessment, your technique and your product selection. Here you can see the multi-layering to avoid the vasculature, but also to give you a beautiful aesthetic outcome. The angle of the mandible has a different arrangement to the rest of the mandibular body. Here you have some structures, some very important structures laterally, not just the masseter, but you have the parotid gland. So anything which is injected below the parotid masseteric fascia, and again, if you can't lift your cannula up here, you're likely to be below the fascia. You're going to be in the parotid gland, which can give you a world of problems. One of the things that we've started to do to mitigate risk is to inject things like RHA4 very superficially. So you have a superficial volumizer able to push that skin envelope forward and avoid some of those deeper structures. This is the body of the mandible. And these are the classic 5 layers that you're likely to see: your skin, your superficial fat, your platysma, your deep fat, and your bone. And what you can see here is your facial nerve, your facial vein, and your facial artery are all deep below the platysma. So now you have an injection strategy for running along the border of the mandible by using something like RHA, a superficial volumizer. You don't need to bury this product deep to have a great surface volume coefficient or projection onto the skin. So again, utilizing your knowledge of your rheology, your instruments of choice, and also your 3-dimensional anatomy can help you navigate away from these problems. So we know that the arterial depths are pretty much a constant here, and you can see that we have superficial, multi-layer, and deep layers here. So we use these arterial depths, and then we build a strategy. These are your lower risk planes of injection. So superficial with a cannula into those areas which are the yellow mustard color, and deep injections with a needle down onto the periosteum. And again, this will help you understand injection anatomy to avoid those complications. So that's a summary from me on a case study, the pathophysiology, and the lower risk planes of injection. So I want to thank you. I will stop sharing and we'll go to the question and answers. We have quite a few questions within the chat box that I'd like to share with Wilson. And what I'm going to ask is, how do we reduce the risk of vascular occlusion for a nasal labial fold injection, Wilson? What's your pearls of wisdom here?
I know there are a lot of discussion there. This is $1 million of questions. So imagine the nasal labial fold. To be honest, most of the time when you see the fold, it's mainly because of the tissue sagging. It's a descent instead of a tissue loss. Think about it, right? So that's why patients always, when they try to remove their own nasal labial fold, they will do something like this. They try to pull up the skin. Can you do something like that? I want this result. So instead of treating the underlying cause mainly, we do otherwise. We lift up the fold inside inner fold. No, not the fold, but the inner aspect, and try to level up to reduce the appearance of the nasal labial fold. So my honest my practice nowadays, most of the time, if they really need fillers into this area, imagine the aging process over this area, nasal labial fold. What happened is first, second is the bone decay. Bone decay over the canine fossa. So if you really want to inject, I think the first area you need to consider is into the canine fossa. Okay, to refill the bone, the bony loss. And then the second thing is you really need to inject superficially, which I have mentioned. Facial nerve is in the superficial fat pad layer. So you need to inject very slowly, not be the needle, be the cannula. If you use cannula, once again, you need to use 25 gauge or bigger size cannula. That's been shown in the study. It trimmed down the intravascular event. But I do see people using 19 gauge cannula, which is huge, end up in the intravascular events. And that happens to, especially for fat transfer as the plastic surgeon. The most fillers. So when you inject, you really need to inject superficially. You have to inject in small bolus and slowly.
And there's no 100% guarantee. There's the safe zone. There's nothing called safe zone. There's a danger zone. There's a lower risk zone, but there's no safe zone. So when you inject, once again, watch out for the pain, especially pain outside the inject area and the branching. Okay. So my question for you, Lee, is what would be your treatment endpoint for intravascular events? So when will you stop? For instance, you see this stage 3 kind of intravascular event, and then you have repeated injection for a couple of times. So you see a little bit of improvement in the circulations. So is there any guidelines or reference so you feel comfortable to let your patient go?
Yeah, so it's a great question. And just to add on to the nasolabial here, we know that the artery, the facial artery, is most superficial and smallest at the piriform. So again, if you're going to inject, you inject deep, very, very slow, looking for all of those signs and symptoms of occlusion. But remember, there's around about a 3 to 4% risk of a periosteal branch deep down. So nothing's perfect here. And again, a cannula with 22 gauge and just very, very slow, because we know the artery can be subdermal or intramuscular in this position. So what's my endpoint with it? Well, one of the great things about being part of a global complications group and being the chair is that you get to see lots and lots of cases globally from this, and you learn how to use hyaluronidase very, very effectively. And one thing we didn't know is that we didn't know how to use it. It was a gift given to us that we were not using very well. We were afraid it's going to cause subdermal atrophy. It's going to cause all sorts of problems. What we have to do is put a context onto hyaluronidase. This prescription-only medicine has been used for over 80 years, and they use it in probably one of the most vulnerable areas of the face, in an enclosed space of the eye, and there is no reported cases of atrophy of globes or any of the tissue supporting the eye. So I think we need to put a bit of context into that. So one of the things that we changed, and we did some guidelines very recently, Wilson, which I'll share with you. They're available open access at the Journal of Clinical Aesthetic Dermatology. We changed the protocol on how you use it, because one thing we know about hyaluronidase now we didn't know is its half-life. So it lasts in the subcutaneous tissue for 5 minutes, its half-life. So that tells us everything we needed to know. It was increasing permeability, it was getting washed away. We use in small amounts, and we'd always get to stage 4, always. 15 years ago, we'd always get to stage 4. 5 years ago, we'd always get to stage 4. 1 year ago, we'd always get to stage 4, until we changed. So we did a couple of things. One is we used a high dose, like Claudio De Laurenti's protocol, 2017, but we didn't use saline, we used lidocaine. And there's 3 reasons why we use lidocaine. Number one, it causes vasodilation, which is what you need in a vascular compromise. 2, it facilitates rigorous massage because it's incredibly painful and you're going to have to repeat the process. And number 3, it actually makes hyaluronidase work more effectively. So we started to use 1% lidocaine, 1,500 units, but instead of every hour, we understood the half-life, we reduced it down to 15 minutes. So the protocol is 1,500 units every 15 minutes in 1 ml of lidocaine. And we don't get to those stages. We're now at the point, like the case with the neck didn't go to the pustular stage. It just, you have that mixed sort of message of edema, those type of things. And that's one of the things you're going to have to do. You're going to have to rethink how you give hyaluronidase and the reasons why you do. You're going to have to put lots in, because now fillers are highly cross-linked, high degrees of HA, and it's a dispersal drug. So that's how I use it. We don't get to that. So how do we treat a pustular stage? Well, we don't even use antibiotics when the capillary refill time is back to normal. Once you get normal tissue perfusion, then the commensal bacteria just go back to normal. So we don't even intervene with these things now. But if you get skin breakdown with the pustules, then my advice would be to use some antibiotics in that area. Wilson, can I ask you a question? Why do nodules form, and how do we treat them, or how do we avoid them?
Well, nodules, I think the nodules formation, if you talk about the HA nodules, I think the most frequent reason for that is the high bolus injections, where we don't understand the underlying mechanism, but we know that the larger the bolus it is, the longer it would be the will it take to be break down by biological process. Now we understand that wherever filler it is, if it is long enough, you will have a capsule formations because of repeated movement and so on. And also large bolus injection, you create bariatric trauma, your blood pressure trauma, and you encourage capsule formations. And the large bolus, you perhaps you have a higher chance to hide those bacteria from inside that bolus, and that can give rise to capsular formation as well. This is a kind of experience we gain from our implants and also previous permanent fillers injections, where you almost always guarantee capsule formations. Wherever actually filler it is, if it stayed long enough, I would say more than 2 years, you almost always guarantee you have a capsule. It's a matter of the thickness and so on. And one question being asked by the audience was that why I treat my patients with delayed hypersensitivity with antibiotics alone. Would I treat them with steroid? Now, because if you look at those delayed hypersensitivity reactions, especially the mild one, and most of the time they are related to a mild grade of infections, and very mild grade of infections combined with certain products, which I've mentioned, those low molecular weight products, which can jeopardize the local immune system. That's been mentioned in many papers. So there's a higher chance that you will get delayed hypersensitivity like that. So for the mild one, I will use antibiotics alone. If they don't respond in 24 hours or they're getting worse, then I will consider to have hyaluronidase injections, perhaps together with oral steroid. So it depends on the severity and depends on the response to antibiotic treatments or not. And luckily, these two patients, they just tied off with antibiotics alone. So one more question is mentioned, asked by the audience would be, he got a patient who had a painful nodule, recurrent painful nodules 3 years down the road. Okay, what should I do? So delayed painful nodule is very hard to treat, very nasty. And I think most of the time we need repeated injection of hyaluronidase plus steroid, and sometimes even 5-FU. And if they still persist, and some people, they will use CO2 lasers. Okay, in the most resistant case, you probably need surgical excision. So this is, luckily, it's really, really uncommon, I would say, in among Asians for those delayed painful nodules for HA.
Again, one of the things we're going to have to think about is the reasons why these things occur. We don't really understand the full phenomenon of delayed onset nodules. We know that cool discrete nodules around about a couple of weeks after, which with no pain and no redness, they're likely to just be intramuscular injections. So injection technique or boluses into the muscle will cause you a problem. One of the frustrating things about it is we don't really test. We don't do anything like C-reactive proteins. We don't culture. We don't do anything. We just tend to give antibiotics or steroids without understanding the full pathophysiology of how these things occur. And that's really the frustrating things. One thing we've moved towards, and like Wilson was said, is sometimes you have to inject the nodules because they become encapsulated. And with ultrasound now, we can guide either the steroids, triamcinolone, right into the nodule, and also hyaluronidase to get through the capsule. Even getting through the capsule with a cannula is pretty difficult to do. And again, with ultrasound, you can help yourself. Again, things like granuloma, you can only call something a granuloma if you have a histopathological report. It's just a delayed onset nodule if it's not. And I'm in agreement with Wilson with these painful nodules. Sometimes people they'll try to deal with them without understanding what they are. So if you've got a painful and persistent nodule, is to refer those cases pretty much straight away, because you don't want to be in a medical legal situation where you've been dealing with something, you don't know where it is further down the line. Pass it on to a colleague who knows a little bit more and can help you. And I'd say surgical excision, especially if it's a granuloma, can be difficult because they have almost like finger-like projections into the tissue. So you can end up taking a lot of tissue away. So the smaller and earlier you can catch these things, the better. So nodules, yeah, they're pretty difficult. So we have some more questions coming through. Again, lots of things like, can you share some injection tips to avoid complications, Wilson? So what are your pearls of wisdom when you're injecting?
When I'm injecting, how to avoid what kind of complications? Excuse me.
Any complication. So
yeah.
I'll give you a couple. How do you avoid nodules first, and then how do you avoid vascular complications?
Yeah. First of all, you need to be conservative. Know your anatomy. All right. You try to mark out the anatomical structures, especially over danger zone on your patient's face. You need to understand your product and select the correct product, and you need to master your technique in terms of the amount, in terms of the level you're going to inject. One point, as I mentioned before, one of the commonest mistake is we try to correct all kind of problem issues with injectable, with actuate alone, which is wrong. Most of the time, we'll end up in problems. A natural result, nodules, overfilling, and whatnot. So rather underfill instead of overfill. All right, you can always give touch up. So and it also involves patient communication as well, because patient communication, try to bring down the patient's expectations and tell them you're going to correct maybe up to 70%, because most of the people, they will be happy with 70% improvement after fillers. For those patients who want more, they can always come back in 2 weeks' time, and then we can give some touch-up injections. Small bolus injection, be conservative, know your anatomy, know the product, and also know the aesthetic ideal. Okay, you know your aesthetic endpoint, and try not to be dictated by the syringe. You are dictated by the end result. So with a current product, with modern product, HA products, most of the time what you see, what you get. So so these are the things I learned over the years. Is there anything you want to add on, Lee?
Yeah, I think you hit the nail on the head at the beginning by pretty much stating use your brain a little bit better and be progressive rather than aggressive with your treatment. Understand depth and distribution of the vasculature. Understand the basics of rheology and what tissue plane you can place your gel into. I always use the saying, you've got to turn rheology into biology to really understand it. And that's how you avoid a lot of the problems. Some people are injecting too deep because they don't have the correct rheology. They've got no option. And again, that could be in a vascular danger zone. I'll just repeat that there's a question which keeps coming up as a repeat about the hyaluronidase protocol. So it's just 1 ml in 1,500 units we use here in the UK, 1,500 units of 1%, 1 ml of lidocaine without adrenaline. Every 15 minutes, just inject that into the whole area of ischemia or blanching that you can see, and then repeat the process every 15 minutes until you've got your capillary refill time back to normal. Now, you can do baseline capillary refills. Again, you can measure the area before you begin to inject and write it down in your notes. Baseline capillary refill time is 2 seconds. The reason why I say get a baseline capillary refill time, you have something to work to with your occlusion. I had a case a couple of weeks ago, and I always do this out of habit, and this lady had a 5-second capillary refill time. She just had slow capillary refill time. And if I would have suspected that at the beginning, and I thought of a little hematoma, I would have been putting hyaluronidase in there forever. So again, get a baseline on the affected and the unaffected sides as well. I think, Krish, that me and myself and Wilson are coming to the end of the questions now, and we need to sort of find a winner, I think, about these questions, because you did this at the beginning. I don't know, Wilson. You're the cleverer of the two of us. I think you should choose the most pertinent question.
You give me you give me the most difficult job. I mean, they are really good questions, great questions here. If you ask me to select one, I would say the how to avoid the intravascular complications for the nasolabial fold. I mean, this is very challenging questions. Indeed, it's not just about injecting HA fillers, but you need to understand this anatomy, aging process, and then treat accordingly.
Exactly. I give you the question because I was the author of the book. It looks a little bit biased if I start selecting people, so I'm just being a little bit neutral here.
Excellent, gentlemen. Thank you. I'll ask Jacqueline and Melanie to make note of the first question who was asked about the intravascular complications in the nasolabial fold area. If I could hold you both gentlemen for one more question, I suppose two parts to this question. And Lee, you're right. We keep seeing that. Where should I inject hyaluronidase? How should I inject it? Is it a multiple site injection or just big bolus? I appreciate the courage of the individual in asking this question. There is nothing like any question is a good question. So if you could take time to answer that. And also the second part to it, is there an upper limit of hyaluronidase that I can use? Because this seems to be coming up again and again. People are hesitant and they don't know. So if you could dispel that, please, James. Thanks.
Okay, I'll go first with this. The evidence tells us that subcutaneous injection is the most effective over intra-arterial. Some people try to recannulate the vessel to flood it through. And remember, it's a dispersal drug. It causes tissue permeability, so it will permeate through the layers. If you feel that you need to inject multi-layer, then inject multi-layer. But as long as you keep the tissue flooded or wet with hyaluronidase, that really is the key. So it doesn't matter whether you use a cannula or a needle. I think needle will cause more trauma, again, clouding the issue. Then cannula, you can just, again, disperse the drug through the tissues pretty easily with that. Second question, there's no upper limit within the literature. We know that amounts up to 200,000 units have been used IV in chemotherapeutics. So again, it's one of the things that we don't really understand. People think, oh, I can only use 1,500 units because it's going to cause some of the problem. We know that the drug is an incredibly safe drug, to the point where we had communications with the British Society of Immunology and Allergy, and they've never even heard of hyaluronidase. Considering it's been used for 80 years, it's incredible that a society like British Society of Immunology or Allergy has never picked up on the radar any problems from this drug. Wilson.
Well, I agree with you. I mean, you can use it liberally, and this medication has been used more than 50 years, and have been used liberally by the anesthetists to help to the LA diffusion for the local anesthetic diffusion. I like your idea, which I've been using. I use xylocaine or lidocaine instead of normal saline, because the reason you have mentioned, and on top of that, hyaluronidase injection is quite painful. If you can add on, because the patients already suffer from pain, from fears, and so on, you don't want to add on extra pains and suffering. So, and that would be a great idea, adding up together.
Excellent. Again, the lidocaine issue is incredibly important here, and it's one which should never be overlooked. As Wilson said, if you've got necrotic tissue or ischemic tissue, which is incredibly painful, and you pour an acid on top of it and then you want to rub it, there's no way the patient's going to go through that. They will stop you, and this is one of the big reasons why you get to that stage 4, stage 5, is that you haven't used lidocaine, you haven't been able to put enough in because it's been too painful. So great point, Wilson.
Okay, excellent. I think we're coming to the end of the session. Ladies and gentlemen, please put your hands together remotely for Dr. Wilson Ho and Dr. Lee Walker. They've been very illustrative and instructive. I hope you have seen from the show and tell examples, as well as the very pointed counsel and guidance they've given you in A, recognizing, B, avoiding, and C, managing complications if you see them. I suppose the key message that's resonating or that's reinforced again and again, there is nothing like safer. We hope this session reinforced to you your good practices, good clinical practices. We hope it made you reflect on things you can do better. This is a Tioxan's commitment to medical education. As you see, I'm pretty proud. Wilson has picked it up right at the beginning of this session. There's been no brand mention at all. It's about us giving you the knowledge and the confidence and the comfort that you could use a Tioxan approach of ATP better in your practices. So with that said, ladies and gentlemen, thank you very much for joining again. We had a fantastic turnout on a Wednesday. Like I said at the beginning, thank you very much for giving up your personal time or your work time to be with us. And I do hope on behalf of Tioxan and both gentlemen and scholars, experts who were there with us, that you found this time productive. Melanie has nicely and very subtly put up this slide to remind you that you have a number of assets available for lower face beautification. They're on the Tioxan APAC app. If you have an iPhone or an Android phone, just scan it. I'll let this be on the screen for a few seconds. Scan and download. There are a number of assets that are clinical, educational. I suppose that can also be properly used in your practices depending on your country and the social media regulations. I'm very pleased that our team are able to do that. Thank you, Jennifer, Melanie, and Jack, who have come up with these resources. So, ladies and gentlemen, that is a wrap. Have a nice evening. Thank you very much again, Wilson and Lee, for your fantastic presentations and for so graciously and generously sharing your perspectives. For the audience, the last comment: if you felt that we haven't addressed any of your questions, please don't hesitate to reach out to our partners or directly to us at Tioxan, and we'll be more than happy to assist you in getting that response across to you. Have a nice evening, everybody. Take care. Be safe.
Bye-bye.
Bye-bye.